everybody. I can assure you in my case, being called an expert is just a euphemism for he's getting old. And I am rapidly. And also, in that same vein, although I'm going to be talking about technology, I really am not a techie, I leave that to my kids. What I'm really talking about is using technology as a tool. And it does not supplant all of the things that we're going to need to do together, but it will help bind us together and make us more efficient and enable us to deal cooperatively in serving a group of patients who really need our care. So with that said, one housekeeping slide, Maimonides is a big hospital. That's really all that says. And most hospitals really focus their attention internally. What happens within the walls of the hospital. Maimonides is a very tertiary care hospital, and we do that. But over the last really almost decade now, we've realized that unless we keep our patients out of the hospital and unless we take a population-based approach to healthcare, we really aren't doing our job. And we see it every day at Maimonides because our emergency room is overflowing. If we can't keep patients out, we can't serve the patients who really need acute care services. So we have developed a number of programs to work with our partners out today because I think you'll see that while they're not all directly involved with the NORCs, they could be, and the desirability is really to link us all together to provide services. Another piece of housekeeping, health information exchange. What are we really talking about here? We're really talking about providing information to all providers at any level of service, and including caregivers and including patients, to make sure that they have the information they need. And what we're not talking about is data. We have lots of data. We're not talking about little bits of data, a number here and a number there. We're talking about real information. And information is really processed data. We have to be able to take data, put it together in some usable form, and, where possible, even to add some kind of decision support to say, how can you best use that data? It doesn't help us to send a patient a blood value without telling the patient what it means and how they can use it and what they need to do to take care of themselves. And we have developed some programs to help do that. As we look at all of our organizations, it's really important to figure out, in fact, what data we need and what data needs to be processed to provide useful information. And it seems really easy. When I started thinking about information exchange, and I didn't start way early on, but I did start before the Rios became a reality. We talked with a bunch of partner organizations about how we could share medication information, and it seemed so straightforward until we started to dissect pieces of the data. So a start date for a patient on a medication at a hospital isn't the same as a start date for a patient in home care. It's not the same as the date that a prescription is filled at a pharmacy. How do you define it? How do you put it together? And it really meant getting everybody in the room and trying to define, okay, what do we really mean and what do we really need to take care of people? So we have to be really explicit about the kinds of data we're collecting so that they can then be processed and run through some clinical decision support, things we call care engines, to help us decide how best to use the data and how best to form it into actionable information so that any user, whether it's the patient, whether it's a physician, whether it's a social worker, has data in a form that they can really take action on. And finally, how do we take all of these disparate groups and pull them together and make sure that all the actions that are being taken here are known by the group of people over here so that we're not redundant and working at cross purposes. So it's really a tall order. It sounds simple in concept, but when you start sitting down and trying to figure out, it becomes a lot more complicated. Why is it important? I think everybody knows, and we actually told us some of the problems that she had experienced at the time of both admission and discharge. Medication reconciliation is well recognized as a problem. It's so easy for a patient to be discharged without a full list of medications, particularly when the providers in the hospital don't know fully what the patient was taking at home. It may not be something that the family knows, may not even be something the patient knows. They come in empty bottles or in unlabeled bottles sometimes. The other thing that happens is patients get substitutions in hospitals, sometimes for the same class of medication. It's just a therapeutic equivalent, and are sent home. Somebody who took Zocor as an outpatient is switched to Lipitor as an inpatient, are discharged with Lipitor, and they think that's a different medication. It is. And so they take both. It happens frequently, and we have to have a way to determine what's really going on. Advanced directives is a clear issue that can affect our patient populations. We really do need to know their wishes, and we don't need to just know their wishes when they come into the hospital or into a specific doctor's office, but all of us need to know what their wishes are. We need to be able to provide care management over the long haul. And this care management really involves every different level of organization. It's not just the hospital, it's not just the primary care physician, it's not just the social worker, it's not just the NORC, it's all of us working together. And we need to ensure that the therapies that are initiated at one place are known and continued at another. So again, a real tall order, and how do you really make that happen? So you have to crawl before you can walk, and we started with some specific disease management programs at Maimonides early on. So about, I guess, 8 or 9 years ago, we looked at the issue of congestive heart failure, working with our partners from Metropolitan Jewish Health System and First to Care to develop a program to manage patients with congestive heart failure. We knew that patients coming into the hospital could be treated, the acute illness episode could be taken care of, we would send them out, and 2 days later they'd be back with the same problem. And usually that wasn't because the patient was non-adherent, it was because the patient didn't understand what needed to happen, or they weren't able to get to their pharmacy, or whatever the reason was. There were slips at transition time. So to try to fix those slips, we developed a coordinated program with our jointly owned home care agency to look at patients at the time of discharge, see what was happening. We assigned a nurse practitioner in the hospital to work with the nurse outside the hospital and coordinate the services that a patient would receive. We identified any patients who came in right in the emergency department, took definitive action, and were often able to take care of an episode and not cause a hospital admission. So we saw our readmission rate reduced from 18 to 8%, which was really quite astonishing. And our average length of stay decreased from what was actually higher than the national norm to the national norm, which actually beats the regional norm. So we did quite well there. This was an intensive interaction between two sets of providers. The data that were given back and forth was on paper or by telephone. A couple of years later, we were lucky enough to receive a grant from the state under the HEAL program to start our first regional health information organization, which is entitled BHIX, the Brooklyn Health Information Exchange. It had to have an X because everyone in the States is but it is BHIX, easy to remember. And it was really started as a partnership among several organizations, really representing the different levels of care a patient needs. And I say that because it's so distinctly different from the way other RIOs were organized. Other RIOs around the city were really interested in patients who hopped from emergency room to emergency room. We said, our patients really receive services from all of us because they need services from all of us, and we need the information. So we started with a couple, actually a few acute care hospitals, Kingsbrook Jewish, Lutheran, Maimonides, Metropolitan Jewish Health System was a member,